Welcome to another episode of Dr. Chen's APA Oral Boards Rapid Review Series. Today we'll be talking about venous air embolism. Now you want to look out for venous air embolism if you get a stem with a surgery in the sitting position, such as neurosurgical procedures or pituitary surgeries, a surgery in the prone position, such as spine surgery. Look out for venous air embolism whenever you have a surgical field that is above the level of the heart, because that is when you have that pressure gradient that increases the risk of air being entrained into the heart. You also want to look out for it if your examiner mentions sporadic sounds from a precordial Doppler, a mill-wheel murmur on auscultation, or sudden hypotension, a drop in your pulse oximetry, or a drop in your end-tidal CO2. In order to properly diagnose venous air embolism, the most sensitive monitor is transesophageal echo. The second most sensitive and less invasive is precordial Doppler, and you place it to the right of the sternum in between the second and fourth rib. You can also see signs such as a drop in your end-tidal CO2, an increase in end-tidal N2, a drop in your pulse oximetry, EKG changes that may demonstrate right heart strain, and always mention that you want to be a vigilant anesthesiologist. Treatment involves flooding the field with saline, placing the patient in Trendelenburg position or whatever position to place the surgical field below the level of the heart, increase your FiO2 to 100%, stop any nitrous oxide that you're giving. If you have a central line, you can attempt to aspirate back and try to get out any entrained air in the right heart, and support the hemodynamics with fluids, vasoconstrictors, and inotropes. And finally, you can try to place the patient in left lateral decubitus to reduce the risk of airlock in the RVOT. However, this last step is controversial and hasn't been shown to improve outcomes. So here's an example scenario. Feel free to pause the video after the question is asked, answer the question yourself out loud, and then compare your answer to the answer that I provide. You have a 68-year-old gentleman undergoing meningioma resection in the sitting position. This patient has a past medical history of hypertension, diabetes, and MI 4 years ago, for which he underwent a 3-vessel CABG. His pre-op TTE demonstrates a normal EF without any valvular abnormalities. During the case, the patient's blood pressure suddenly drops from 120/70 to 68/30. You also hear sporadic roaring sounds on the precordial Doppler. What would you do? The drop in blood pressure as well as the roaring sounds on precordial Doppler is consistent with venous air embolism. I would immediately alert the surgeon. I would ask him to flood the field with saline. I would place the patient in Trendelenburg position, support the blood pressure with fluids, inotropes, and vasopressors as indicated. If I had a central line, I would aspirate on it to try to remove any entrained air in the right heart. In addition, I would ensure my FiO2 was at 100% and that I was not running any nitrous oxide. I would call for a TEE in the room to further evaluate the heart.